Okay, so when you're thinking about the patient, certainly in the UK system, and I think it's fairly common elsewhere, is you get referred somebody, you get sent a letter. And obviously put to read the letter. Sometimes they're very scant, and sometimes they're reasonably informative, but at least they set the scene usually as to what broad area you're going to see somebody in. It might be balance problems, it might be weakness, it might be stiffness, and so you get an idea. I always think it's not only polite but appropriate to go out and meet the patient, but I do it not just for those reasons, but also because it allows me to see the patient move. It allows me to see how they get out of the chair, if they're using walking aids, are they in a wheelchair, and how they maneuver things. It's actually important because you get a good sense even of the non-organic, the functional patient, in watching the first time they move, particularly when they think you're not examining them. So I find it an incredibly useful first step. Here you introduce yourself and you shake their hand. And when you're shaking their hand, you get a sense of whether they've got coordination problems. You can look at the muscles in their forearms and their hands, and you can feel the muscles in their hands as you shake their hands. So you get quite a lot of information, literally, from these very simple introductory 20, 30 seconds. And then you obviously ask more than a couple of questions, but I have two questions that I pay most attention to. And these, first off, are: when does it start? Is it a young onset disease? Is it a late onset disease? Somewhere in between? And I also ask about the course. When I mean course, I actually also mean pattern of onset. Is it an abrupt onset? Is it an insidious onset? And then once it started, has it stayed static? Has it repaired in some way, if incompletely, or has it progressed? These are fairly standard things. And this applies whether we're talking about a dystonic illness, an ataxic illness, a neuropathic or myopathic illness. So it works really well across the patch. What I'm going to just illustrate here, though, is I've just taken the idea of the ataxias just to illustrate where I'm going, but the same principles, obviously a different list of potentials, but comes to mind. So for the ataxias, is it early? If it's very early, were they born with it? Now that's difficult with ataxias to tell whether a toddler is ataxic, because all toddlers are ataxic by definition. So you have to do a little bit of probing on that. If it's early onset, we generally think about recessive illnesses because they tend to be early onset. And if they're adult onset, they tend to be dominant. In this case, the autosomal dominant cerebellar ataxias. That's a rule of thumb. It's not absolute. Of course, there are some late onset recessive diseases, and there are some early onset dominant ones, but it's quite a good rule of thumb. And then for the ataxias, if it's, not everything's genetic, you've got to think about other causes. So age of onset, early is congenital or recessive, adult is dominant until proven otherwise as general rule of thumb. And then, of course, with the onset and the pattern of the disease, in genetic terms, we're usually looking at insidious onset and progressive disease. There are exceptions where things are static and that can be genetic, and there are one or two very, very rare exceptions where some things happen acutely, stroke-like episodes in mitochondrial disease and so forth. But broadly speaking, the genetic conditions are insidious in how they start and slowly progressive thereafter. Okay, so I just want to illustrate what we do as clinicians. So here's some notes. This is notes from my hospital from 1895. The patient was admitted under Dr. Gowers, as detailed on the top of this slide here. And he came in with ataxia, and somebody, and I don't know who wrote this, has written query paralysis agitans here in the top box here that I'm pointing out, hopefully you can see with my cursor. And that's the old-fashioned name. This is from the late 19th century for Parkinson's disease. So somebody at this point spotted that not only did this guy have ataxia, but he also had something that we now call Parkinsonism. So the phenotype was being described then. That family were written up in the 1920s by MacDonald Critchley, again in the 1980s by Anita Harding, and then eventually the family, who we still follow up, were known to have SCA3, proven in the 1990s. So it was good clinical phenotyping over 100 years ago that allowed us to characterize the clinical characteristics of the disease. The other thing, just to briefly, and I'm not trying to teach, this is stuff we learned at medical school, but it is worthwhile getting a good note of family history and the mode of inheritance. It doesn't take long to ask ask a proper family history. People think it's burdensome, but it actually isn't. Okay, somebody has a very complicated family history. It may be, most of the time it's quick. And you really need to discern the difference between no family history, i.e. you haven't asked, or no family history because the person doesn't know, they're estranged from their family or they're adopted, or there is no family history. So no family history means several things, and you have to work out when you're taking history or when you're getting history from your registrar what they actually mean by that. And shown here are the different major modes that we think about: dominant, male-male transmission, going through 50-50 equal sex gender ratios. Then below that you've got recessives. Sometimes there's consanguineous marriages, as shown by the family on the left there, or cousin marriages, and sometimes you've got recurrence in sibships. But to be honest, because sibships tend to be small in most families nowadays, you often find a singleton case. So singleton cases can turn out to be recessive. So although these look easy to spot, they're not always in the clinic. And then you remember with X-linked, you're looking for the absence of male-male transmission and the predominance of males. The reason I say predominance rather than absolute males is because in neurology, there are a few exceptions where you see X-linked dominant inheritance, where you see manifesting females. I'm thinking of Charcot-Marie-Tooth type X, and also adrenomyelin neuropathy, where you can see manifesting females. And of course, as neurologists, we must never forget the matrilineal inheritance we see for mitochondrial disease. So as clinicians, really what we're doing when we're assessing the patient is clarifying the phenotype. And of course, you do that first by examining them, and then you're planning appropriate investigations. So I'm just going to point out a few things. I can't obviously go through everything in the time available. So clearly, you want to establish they do have, in this ataxic example I'm giving you today, do they have other features? Do they have pyramidal signs? Do they have neuropathic signs? Do they have myopathic signs? Do they have ocular disease? So shown here are three different things you might see in complicated neurogenetic cases, not just the ataxia. So on the left, you've got retinitis pigmentosa. In the middle, you've got severe macular degeneration. And on the right-hand side, you've got a pale disc of optic atrophy. So it's always worthwhile looking in the back of the eyes. You've also got to think outside the nervous system. This is an example of Friedreich's ataxia, shown with the scoliosis and the cardiomyopathy. This example here with the eye is ataxia telangiectasia with the blood vessels in the eye. You've got things like hepatosplenomegaly and Niemann-Pick. So you've got to be able to assess somebody out and think outside the purely neurological framework. Clearly then you want to think about the appropriate investigations, and before you jump right to the genes, you want to be thinking clearly, do you want to image something? Do you want to scan them? Do you want to do some other data imaging and so forth? What about neurophysiology? Can that give you some insights? And generally speaking, with complicated, potentially neurogenetic cases, then I have a low threshold for both imaging and physiology. And I see it really as a way of clarifying the anatomy. You've got the structural anatomy clarified by imaging, and you've got the physiological anatomy clarified by neurophysiology. Now, sometimes you're doing that because you find a subclinical neuropathy, which isn't apparent on bedside examination, but your neurophysiologist can tell you about it. And an important differentiation here, of course, is the demyelinating versus axonal. Nearly all the neuropathies you see in genetic cases turn out to be axonal. And it's the exceptions that are demyelinating, and the exceptions help illustrate the diagnosis. Obviously, in Charcot-Marie-Tooth, that's a very clear classification system, demyelinating axonal. I'm talking here about the non-Charcot-Marie-Tooths. And so you've got to work that out. And then you've got to think about appropriate blood tests. And in particular, for the sake of this our audience today and this talk today, genetic tests, which ones and when. And what I want to do here is go through the recent past, i.e. where we've been up to, where we are right now, and where I think we're going in the near term. So imaging, so for ataxia, you often end up just with showing an atrophic cerebellum, as shown here in the top panel here, but occasionally you see this is called the molar tooth sign. This is a sign of congenital ataxia Joubert, or you see some signal intensities in the peduncles. So you sometimes get some hints of to what's going on genetically from the imaging, but more often than not, you end up showing atrophy because it's a degenerative process. Physiologically, this has become important in some branches, particularly the ataxias, that you can use OCT, optical coherence tomography, to look at the retinal thickness. This looks at, it's a direct way of measuring neuronal integrity, if you like. And there's actually quite a lot of conditions neurogenetically that can show atrophy in the OCT appearance at the back of the eye. And it's a bit like showing an axonal neuropathy. It just quantifies the anatomy and tells you the degeneration going on. But there's a condition, RSACs, in which you see hypertrophy of the retinal layer, as shown here. And that's a very distinctive, and to my mind, almost pathognomonic feature of that particular condition. So I don't do OCT a lot, but it is useful, particularly in the ataxias. So if we think about the ataxias for a moment, we call early onset below the age of 20, and it's nearly always recessive. Late onset over the age of 25, and it's nearly always dominant. And the X-linked forms exist, but they are pretty rare. Now, this pattern, this rule doesn't apply absolutely to the dystonias or the spastic paraplegias, but the age of onset guidelines here are not that far off. Generally speaking, I err towards being recessive if it's early onset and more likely to be dominant later onset. But of course, you take a family history and get more stuck into that. So if we continue thinking about ataxias, so this is the recent past and where we are now, you can test for a bunch of spinocerebellar ataxia genes, you can test for Friedreich's ataxia, and you can test for the Fragile X tremor ataxic syndrome and a few rarities. But in the last few years, and this is just taken from different labs in the UK, just as an example, you're not meant to remember all this, of course, is you can see that in this one lab here, they do 107 ataxia genes, and they do another 52 if they draw a blank in these 107. So you get 150 odd, 160 ataxic patients, ataxic genes sequenced really quite quickly and in some depth. Now, some patients are complicated, and this is why they're listed in panels, but it might be, they didn't just have ataxia, they actually have dystonia and Parkinson's, so you do this panel. So essentially what you have to try and remember is that nowadays it's quite widespread to be able to order a panel of spastic paraplegia, a panel of dementia, a panel of ataxia, and so forth. But you've also, if you've clarified the phenotype, sometimes you can ask the lab to do more than one panel because it's appropriate to do so. Now, where are we going? Of course, everybody knows that whole genomes are available. They're very cheap now. This is the plot of how the cost has diminished, the yellow line here. You know, at the turn of the century, it was well over 100 million a genome. 10 years ago or so, it was still $10 million a genome, and then it's just fallen off a cliff. And then 7 years ago, it went down to $1,000, which was kind of the sort of golden thing they were looking for. It's actually below $1,000 now. So getting hold of whole genome data is no longer prohibitively expensive. Making sense of it is difficult. So there are some limitations with whole genome. First off, it isn't exactly the whole genome, and that's because we haven't what's called annotated the whole genome yet. So we don't actually know how where to look at everywhere. So there's still some work to be done there. It isn't good for repetitive sequences, and as we know from neurology, repetitive sequences are very important to neurologists, the scars in particular, but there are others. And it isn't good for copy number variants, i.e. more duplications and deletions in large numbers. Let me just give you a quick example here. This is a clarified phenotype by my own hospital some years ago by Dr. Bronstein and Linda Luxon, called CANVAS, this ataxia with sensory neuropathy and a vestibulopathy. Now, this is work done by Henry Holden and Mary Riley and published about almost 2 years ago now. And what happened here is you can see the sequencing on the lower panel, and those grey blocks is that they basically obtained sequence. On the top panel is the patient, and they missed sequence. So the white space is something missing. So they knew something was missing, but they kept going because of linkage. So they had linkage, a log score here of almost 6, which made them be persistent and dogged at working out what was in that missing bit. And they went on to find and describe this interesting pentanucleotide repeat, which explained a very significant proportion of these complicated ataxic patients. And it's turned out to be a very important discovery. Now, the reason for highlighting that is not to talk specifically about CANVAS, but to leave you with the impression and the sense that there is more things to be discovered. We know that we haven't discovered all the genes yet, and there might be more things like this out there. 10 years ago, I'd have given the example of ALS and C9orf, and here's another one. So I think repeats still have a lesson to us all in neurology. Okay, I'm coming towards the end now. So this is the way we translate things. We find genetic variants. Well, now we can do that quite easily with whole genome sequencing, even given my caveats. But proving causality is proven more difficult. And I think Henry will perhaps go into this in some detail, because until you know a variant is causing the disease, you can't actually use it for clinical diagnostics. Of course, as scientists, we're there to determine biological function and the genomic function, and Mina Reiten was going to go into this later. And then, of course, we're doing it not just to butterfly collect genes, but to influence that function. Let me just see how to finish off with how we might do that. Here's a genetic condition, spinal muscular atrophy. As we all know, maybe in this audience, it's a really unpleasant disease. Lower motor neuron disease comes on very early in life, and in its most severe form, it produces massive disability and very early death at around the age of 3.5 or 4. This is some genetic therapies, and there were 2 papers published back to back in New England Journal just over 3 years ago, end of 2017. And this is, instead of these 3 children shown here, the CHOP score is how their motor scores essentially, and they should degenerate. They should go downwards like this, and they don't. But even more impressive is when you look at the high dose. These are just astonishing results. And so they had to stop the trial because it was immoral and unethical not to stop this. It was so powerful. So this shows that if you identify a genetic group patient early enough and you have the right design genetic therapy, you can fix complex neurogenetic deficits. So I want to leave you with that hopeful image of treatments which are emerging. And I think we'll see a lot more of this over the next 5 or 10 years of specific genomic therapies coming online.